Hello and thank you for joining me. Today we're going to talk about vitamin B12 deficiency, which isn't just about anemia. It can quietly affect the brain, the nerves, and even mimic psychiatric illness. In this video, I will cover the clinical presentation, diagnostic approach, and treatment of B12 deficiency anemia in a way that is clear, concise, and clinically relevant. Because let's just be honest, if you miss B12 deficiency, your patient might forget more than you did for your last exams. Subscribe for more focused medical content and let's get started. So we're going to start with why vitamin B12 is such a big deal, especially in its two active forms, methylcobalamin and adenosylcobalamin. Think of B12 as a tiny molecular assistant, like that overworked health worker in a hospital who quietly keeps everything running until they vanish and chaos breaks loose. So methylcobalamin, it works with an enzyme called methionine synthase, and together they help convert homocysteine into methionine. Okay, now without vitamin B12 in the form of methylcobalamin, homocysteines will start to build up. Okay, and here's the catch: high homocysteine levels can activate platelets as well as cytokines. Okay, so it is going to be a risk factor for ischemic heart disease, for example. Now, the second one is adenosylcobalamin. This one partners with the enzyme methylmalonic CoA mutase, and it helps to convert methylmalonic acid into succinyl CoA. Without vitamin B12 in the form of adenosylcobalamin, what happens is that this substance MMA starts to build up. And so this buildup can damage myelin sheaths, those protective coatings around the nerves. Okay, imagine trying to send a text message through a frayed charging cable, slowed signals, missed messages, maybe even sparks. You're thinking, what is he talking about, right? That's how your neurons feel without vitamin B12. So clinically, B12 deficiency doesn't just lead to anemia, it also increases the risk of ischemic heart disease due to homocysteine levels and also damages nerves and slows neural conduction due to methylmalonic acid accumulation. And all this because one tiny vitamin didn't show up to work. B12 may be small, but it has a very big job. Another critical role of vitamin B12 is in DNA synthesis, that is B12 as a cofactor. Vitamin B12 is necessary for DNA synthesis, specifically in the production of thymidine, which is a nucleotide required for building DNA. Without vitamin B12, thymidine synthesis is impaired, and as a result, DNA replication becomes inefficient. To understand the impact, let's briefly go over the cell cycle. So at G0, the cell is inactive, not dividing. At G1, the cell grows and prepares to replicate DNA. During the S phase, which is called the synthesis phase, this is where DNA replication occurs. And during the G2 phase, this is final preparation before division, and the mitotic phase where the cell divides. Okay, in vitamin B12 deficiency during the synthesis phase or the S phase, DNA synthesis slows down due to the lack of thymidine. Meanwhile, the cytoplasm continues to mature, but the nucleus remains underdeveloped. This mismatch leads to the formation of a megaloblastic, you can see right there, megaloblastic cells, large immature cells with unbalanced nuclear to cytoplasmic development. So importantly, this defective DNA synthesis doesn't only affect the red blood cells, okay, it affects all rapidly dividing cells in the bone marrow. So we are talking about leukocytes, there's going to be a leukopenia, we're talking about the platelets, there is going to be thrombocytopenia, and obviously there's going to be decreased red blood cells, so anemia also occurs. So in general, we will see something called pancytopenia. Okay, many students associate B12 deficiency mainly with anemia, but it's important to remember that it can affect all three blood cell lines. In fact, it may even resemble myelodysplastic syndrome on peripheral blood smear or bone marrow biopsy, which is why proper diagnosis is essential especially since B12 deficiency is treatable. So, vitamin B12 deficiency can present in wide variety of ways affecting the blood, nervous system, and even mental health. So, we're going to start with hematologic symptoms, and anemia is the most common presentation. Patients may complain of fatigue, weakness, dizziness, pale skin, tachycardia, chest discomfort, a low blood pressure, or even syncope in severe cases. You may also notice glossitis. The tongue appears beefy, red, and sore, sometimes with smooth patches referred to as bald tongue. Not a good look, but a great clinical clue. In some cases, hemolytic anemia can occur, possibly due to the elevated homocysteine levels activating complement and inflammatory pathways. The combination of anemia and mild jaundice from the hemolysis can give the skin a lemon tinged appearance. One of the hallmark features is subacute combined degeneration of the spinal cord, primarily affecting the dorsal columns, leading to loss of proprioception and fine touch. This involves the gracial and the cuneate nuclei. The lateral corticospinal tract is also involved, resulting in motor weakness, spastic paresis, and a positive Babinski sign. Patients may also experience paresthesia, tingling and numbness, ataxia, that is unsteady gait, loss of ankle jerks, as well as autonomic symptoms, that is bladder, bowel, and sexual dysfunction. Neuropsychiatric symptoms. This may occur even in the absence of anemia and include poor concentration, memory, sleep disturbances, mood changes, depression, and even delusions. Early recognition is key because, unlike many neurologic conditions, this one is reversible with timely intervention. All right, so diagnosing vitamin B12 deficiency starts with a good clinical history, followed by targeted investigation. So you need to ask questions about diet, especially in strict vegetarians, since B12 is found primarily in animal products. Check for medication compliance, review medical and surgical history, including gastric or bowel resection surgeries, Crohn's disease, chronic pancreatitis, as well as atrophic gastritis, often seen in older adults or autoimmune conditions. Laboratory investigations will show a decrease in red blood cells as well as hemoglobin, indicating anemia. Okay, we also see macrocytic cells. The mean corpuscular volume is greater than 100 femtoliter, which implies macrocytic cells. We also see hyperchromic cells because the mean corpuscular hemoglobin concentration is also elevated. Now, this may happen or occur with a decline in the white cells as well as platelets. So we have leukopenia or thrombocytopenia. Okay, peripheral blood smear right there, as we already mentioned, we see macrocytic cells, we see hyperchromic cells, and there is a characteristic neutrophil that I need you to take a look at. You see that the neutrophils are hypersegmented. Neutrophils normally have about 3 to 4 lobes, but in this case, we see that these neutrophils are hypersegmented in vitamin B12 deficiency. Sometimes you would also see something called Cabot rings. It may be a loop or it may be a figure of eight, kind of a remnant of the mitotic spindle. So when you see Cabot rings, that could also be a sign of vitamin B12 deficiency. So we certainly need to assess B12 and folate levels. Okay, now always check both. It is important. I need you to understand that giving folic acid without checking B12 can correct the anemia, but it will worsen the neurological symptoms, which is a very avoidable mistake. So if you do not know the B12 status, it won't be advisable to start folic acid in a patient who is suspected to have vitamin B12 deficiency. Okay? Additional tests may include lactic dehydrogenase, often elevated, and this is due to increased cell turnover. We also see homocysteines and methylmalonic acid levels. They may also be elevated, and especially it helps in borderline cases. Right now, it's very important to take note of this pernicious anemia, which is caused by autoimmune destruction of parietal cells or intrinsic factor. So here we need to test for antibodies. Okay, So we're going to test for anti-intrinsic factor antibodies and anti-parietal cell antibodies. They are positive in majority of the cases, but it might also be negative in about 3% of the cases. So a negative test does not rule out pernicious anemia. Okay. Another thing to remind you of is Schilling's test. It is an older test used to assess B12 absorption. It is obsolete now, but it is worth knowing for exams or trivia nights at medical school. Treatment of vitamin B12 deficiency is generally straightforward, but the route of administration depends on the cause. So let us discuss vitamin B12 replacement. The two commonly used forms are hydroxycobalamin, which is the preferred, and cyanocobalamin. The route of administration depends on the cause. So for example, in pernicious anemia, in malabsorption, in GI surgeries, example, gastric bypass, terminal resection of the ileum, okay, or intrinsic factor deficiency. In these cases, you would have to use IM vitamin B12 in the form of hydroxycobalamin, okay, because oral B12 won't be absorbed effectively in these cases. IM is the go-to when the gut is not cooperating. Dietary deficiency, example, strict vegetarians with intact GI tract. In this case, oral B12 tablets can be effective. There is one more thing I want to say before I end this. So think about this. You started treating B12 deficiency, and now the DNA synthesis kicked in. The patient is making more red blood cells. One thing you should know is that sometimes these red blood cells starts to pick up the potassiums from the blood, and so the initial treatment can lead to hypokalemia. A point you should note because the exams or the boards can ask you that. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.